This may be a topic which may not be suiting the basically theme of the conference, but this is a hot topic these days, especially also for the surgeons, because surgeons are required in having the good outcome of transcatheter aortic valve implantation. So insights into innovation, why I chose this topic, because I worked with Professor Alan Crebier, who is the father of TAVI, in 1996 to 98. And at that time, he was contemplating, thinking, and trying to find a company. So I work in Apollo Hospital, and this is my tribute to Professor Alan Crebier also. And also I want to share how innovation actually takes place so that we can have new innovation. So these are a few slides. My wonderful stay in Rouen from 1996 to 98. I was working in the cath lab with Alan Crebier, who was one of the best angioplaster also. And we had a good surgical team also in the backup on the 4th floor. I was in the 3rd floor of Charles Nicolle Hospital, Rouen, which is 30 kilometers from Paris, and one of the largest hospital, public hospital, with 4,000 beds capacity. So these are few slides which I had to do, and I worked with 96 to 98. This was the first case of TAVI, transcatheter aortic valve implantation, done in Rouen from India. And in 2011, TAVI was still not available in India. DCGI had not approved it. And we had to fly this patient. The patient flew with me after workup from Apollo Hospital, Delhi. And we did the first case at what's XT valve. So first in man, a vision by the pioneering team, Alan Crebier, Rouen University Hospital, was done in actually April 2002. And this was the 20th celebration of the same in 2022 in Charles Nicolle, with more than 500 participants from all over the world. Few memorable videos I would like to share, because unfortunately Dr. Crebier is no more, and he just had a sudden cardiac arrest last year himself, and he had a, but doesn't matter, we have good memories with him. So I would like to share a few of his videos very quick. This was the last video which I recorded with him in 2023 December when he came to Kolkata. Can we have the volume in this? Can we have the volume? But I just wanted to hear a little more from Dr. Crebier. But before that, I will. Can we have the volume of this? If not, then I will skip. Okay, so this was one of the few videos which I had in 1997 working with him in Rouen, where he used to do good complex angioplasties. This was Dr. Crebier himself coming to my residence in Sarita Vihar, and I had a very special affectionate relationship with him. And I want to show this few quick few seconds of each video before I go on to the main topic. So he was the most humorous person. He had kept the tissue paper on my head, and something very always ready to help, and one of the best humorous person I've ever seen. And I have never seen anybody criticizing him. He was having good relationship with all the surgeons, with doctors, with interventional cardiologists all over the world. And a small thing which I would like to share, he would like to do something I would like to share, and before I go to the next slide. So this was a... You say something? Well, actually, it's even he's not doing anything. So this was humorous which he was doing. So before, this was a car ride with him in Rouen, Charles Nicolle, top man of the world, and with the Rouen, and this was the 20th TAVI celebration. And the way he used to love me, I would like to share a few seconds of this. In Rouen, when 20th TAVI celebration, he was a hero. Most of the world interventional cardiologists and also surgeons were there. He was a pianist himself, and this was during the stay on bicycle. My son, who is now a doctor himself, in 97, 98. So he also gave some addresses, because we started Indo-European conference in cardiology. That was 2008, and he used to give, when he was not able to come, he used to give messages sitting on his piano. This was also one of the interviews with him. I don't want to go into details. And now coming on to the plan of presentation. So what I want to tell that Professor Alan Crebier, one of the best interventional cardiologists I have ever seen. I've been to USA more than 30 times. I've worked with many other hospitals, but he was a fantastic person, and I have a small. Coming on to the TAVI, which is a scope for the degenerative aortic valve stenosis, balloon aortic. When he was contemplating, so this is a slide which I have taken from him actually. So the lessons learned from this experience for the future innovators. Having an idea is not enough. Having an idea is not enough. Translating into the reality requires a combination of elements Failure of any one of these can lead to failure of the entire project. Never give up. Perseverance is a key word. So he had to actually had a lot of problems during the time when he thought of it. 1985 in Rouen, development of two successive innovations for the non-surgical treatment of acquired aortic stenosis. The first was 1985 balloon aortic valvuloplasty. He was a but aortic valvuloplasty required some more strength and mental strength and quickness and of course pacing the heart. So single core of these two linked innovation to provide a life-saving therapeutic option for patients with symptomatic aortic stenosis and decline for surgical valve replacement. At that time, more than one-third of the symptomatic years non-operable, especially mortality at the age of 80 years was 2 years follow-up. So it was the reason why he wanted to do something where the patient would decline for surgery and therefore the management. Now I said 1986, a bomb effect of the medical community, give up or fight. Tens of thousands of patients treated, but of course there was a stenosis coming up, recurrence of the aortic valve stenosis. There were non-lasting results, early valve stenosis 80% in 1 year. So this was the reason why there was a need for a transcatheter valve replacement in the patients who are not surgically, at that time, not surgically possible to be treated because of so many complications. TAVI, the 15-year long walk from the idea to first in man. What were the experts said at that time? Two engineers, J&J, Johnson & Johnson, two cardiologists, they said the most stupid project ever heard, just forget it, that was 1994. So the reason why they said not possible to do it, the companies which were actually responsible for answering this on the email or fax at that time were Medtronic and Edwards. And this was approached by Dr. Crebier, Medtronic, Edwards. Now they are selling this TAVI hot cake like a hot cake. The same companies had said no, we will not finance it. We will not finance it. So Ruha, this is the road, 15-year long walk. BAV 85, 87 project balloon expandable stenting valve, first announcement. Ruha landmarks autopsy study was done in 1994. I was in 96. At that time, he was still working with the company. They were looking for sponsors. All biomed companies contracted. Nobody supported the finance. 1994 to 98, complete failure. Opinion of experts, the most stupid project ever heard. Just forget it. Then they created their own company, PVT, Percutaneous Valve Technologies, with the help of New Jersey, USA, Dr. Martin Leon. Dr. Crebier himself made a company coming from finance from Israel, two engineers from J&J, two cardiologists, Alan Crebier and Martin Leon. Partnership was done with Israeli company, which made the prototype, and the PVT heart valve prototype was made in 2000. This was tri-life polymer. The surgeons will understand better than me. Horse pericardium was used, stainless steel stent, single diameter 23. This was actually designed by Israeli engineers in 2000 with the help of the company PVT, with Martin Leon and Dr. Aaron Crebier, because Medtronic, Edwards, all the companies declined to fund it. After this, the first one man was from dream to reality was done in 2002. Of course, before that, there was a preclinical evaluation, extensive in-lab Israel and in vivo testing, sheep model, more than 100 or more than 80 cases in the sheep was done, and this was actually possible to do it. So this was the 16th April, this was the patient I want to highlight. This was a dying patient, 57-year-old, young man, cardiogenic shock, the first in man I'm talking, EF of 12%. I'll take 5 minutes more, sorry for the time. Aortic valve area of 0.68, bicuspid aortic valve, multiple comorbidities, acute lesion ischemia, occluded aortic bifibular, floating thrombus in LV, no femoral access. This was planned to be done actually by an integrated approach, but failed transeptal BAV. TAVI was the last resort, unplanned transeptal. It was unplanned. It was on the table. They decided to do a transeptal approach. They went from inferior vena cava to RV, the right femoral vein, to inferior vena cava, to right atrium, to left atrium, transeptal, from left atrium to left ventricle, and then putting the wire into the aorta transeptally across the valve. This is what they did, and this was done successfully. The second bomb blast within the medical community, enthusiasm, incredible, and fury of cardiac surgeons came again. So this was the case, very difficult case. I really give a lot of comments to Dr. Alan Crebier, who could decide to go from retrograde rather than from integrate to retrograde. Coming from transeptal approach would not have been easy, especially on table with a cardiogenic shock patient. And he did successfully patient live for few years after that. So this was a dream come true vision of a cardiologist. From 2002, which was the first case, to 2005, there were 38 compassionate patients. That means those who are very sick NYHA class 4 imminent death transseptal approach was used in most of them. 50% survival in 1 to 6.5 with return to normal life. Few role of patients. Few patients who were celebrated they had from 2002 to 2005. The first step in TAVI offshore, then John Webb from Canada, Vancouver, Bernard Detroit, Martin Leon, New York, Rwanda, of course, Dr. Rotterdam, Patrick Saras, one of the very important cardiologists, interventional cardiologist, and Antonio Colombo from Italy. So 2005, the 100 patient mark was passed. 2002, 2005, 100 patients were done. TAVI enters a new era. Same company, the Edwards, which had refused the idea, now buy or overtake PVT. So now this is Edwards now. So Edwards took the from 2004. The Edwards came into picture. They said this is a very important project and we should take it. Creeper Edward valve was the first valve, the name, and then after when the patent was over, it was known as Edwards Sapien. Equine pericardium, 1/3 of external coverage, 23 and 26 millimeter. Earlier it was only 23 millimeter. Treated bovine pericardium. It was equine pericardium. Now bovine pericardium was used, 50% external coverage. And then John Webb came with a more extensive antegrade approach, which is now being used regularly, MAC and one Mayer, although Dr. Krieger had the same idea, but he continued to do transeptal, then of course antegrade approach. So 2005 launch of concurrent device, which is Medtronic, it is self-expanding. This was balloon expandable valve, which was Krieger Edward valve or Edward Sapien valve. Now this was self-expanding. Same time they started working from 2005, and now the Medtronic has taken over this. From 2005, no one could have predicted the prestigious expansion of TAVI over 20 years. The reason of success, continuous and rapid technological improvements, making TAVI easier, faster, safer, major drop of severe complication, patient selections with the help of CT. The predominant role of MSCT came in 2010 with TE and TE guidance, anatomy and valve sizing. Now ex-Mencio analysis is done, which we did during that time. So Edwards Sapien 2005, Sapien XC 2009, Sapien 3 in 2012, and in 2020, Sapien 3 Altia. Now we using Regilia, which has been used regularly from Edwards. Same time, Medtronic core valve, Evolute. These are self-expanding devices. These are balloon expandable devices. And of course, Boston Scientific and Merrill from India has also come up with my valve and Doctor core valve. So reason for success, transfemoral approach has become the default strategy. Transapical, transapical, transaxillary all have gone. 95% of cases as of 2021. So the reason for success was that 2 operators, 1 fellow, as this was a conscious sedation patient. In America, most of the time they were using general anesthesia patient with a TE, while in Rua or in other part of the Europe, there were local anesthesia, pure percutaneous approach, no TE, per closing system, which is ProGlide, procedural duration 30 to 40 minutes, patient discharge in 3 days, in most of 75% of cases published in JACC. And then, of course, the further partner 1 and partner 2, partner 3 trial required. In France, there were multiple registries, France 2, NEGM, fast TAVI registries, mass registry, let's say SAVR, randomized trial from such, but randomized trials of TAVR versus SAVR, decreasing risk with Edwards and Medtronic TAVI system, and 2023 as SAVR is indicative of outpatient, not optimal candidate for TAVI. Partner 1 trial was important because they compared the surgical valve replacement versus transcatheter, inoperable high risk. They confirmed that inoperable high risk, it can be done, and that gave the approval of FDA. Then partner 2 was intermediate risk, and partner 3 was low risk patient, more than 75 years age. And of course, 2019, FDA approved for the low risk patient. Non-inferiority or superiority of TAVI was established, and partner 3 and 4, partner 3 trial compared, and similarly compared with Medtronic core valve, which is a self-expanding valve. And then hypothesis of TAVI was there when FDA approved TAVI for the low risk patient more than 65 years, not in young patients. Medtronic, Evolute and Sapien 3 both. A total of 30 lakhs patients have been done, 3 million patients have been done worldwide in 80 countries. TAVI markets succeed surgical aortic valve market in many countries, including USA. Expected growth. All the future of TAVI looks brighter. Should we always pre-dilate? This was the case which we did recently, and we did not do pre-dilatation. Earlier they used to do pre-dilatation. Now the pre-dilatation not required. You can do direct stenting type of procedure. Pre-dilatation had some disadvantage. This was the recent case, which was Edwards Sapien 3 with a valve area of 0.6 from Apollo Delhi. And then we had this. Dr. Mukesh Goyal was also involved, sitting here right here with our cardiac surgeon. And he was there, and this is the post result. And there was neither pre-dilatation nor post-dilatation, which was required in such cases. Pre-dilatation has some problems, especially because you may have some sort of a cerebral stroke or something. So if you are confident enough, the pre-dilatation may not be required. But in self-expanding valve, most of the time you have to require pre-dilatation. I just finally finish off with the first case which we did, with the 83-year-old male, he was actually a severe symptomatic aortic stenosis, patient treated with recent on symptom, 0.7 of valve area, peak greater than 75, long-standing diabetes. He was actually declined by the surgeon, and surgeon referred to me that you have relationship with Alan Crebier, why don't you take him to France? Because at that time, India, DCGI had not allowed, or it was not approved here. It was not possible to do this case. 18 French femoral sheet, now we are using 14 French, no flex sheet, Edward XT while concentration. I was scrubbed as second operator, but the patient time was at that time was only 40 minutes, and you can see a few videos of that pre-dilatation, and then of course crossing the aortic valve, then doing a pre-dilatation, then of course putting a safari wire, extra stiff wire, and then putting the valve. This is the valve which is going up, crossing from the aorta, descending aorta to the transverse aorta to the ascending aorta, and then right at the valve, and then you do pre-dilatation, post that dilatation. It's a balloon expandable valve, and then the valve is deployed. The patient came with actually there was some peripheral leak in this patient, which really did not require a post dilatation at that time. Coming into the last, the patient minimalist environment without infusion of TE, without general anesthesia, with conscious sedation, 45 minutes procedure. I was myself scrubbed. It's the first Indian patient treated of TAVI, but of course not in India, but outside India. So I would like to just give you there are few remaining issues, which is for the young patient, for the bicuspid valve, for the highly calcific horizontal aorta, which is coming up soon. So some remaining issues of minor complication, PVL, requirement of permanent pacemaker implantation is very less in the balloon expandable valve as compared to the this is preserving selective coronary access, higher prevalence of bicuspid valve, prepared to increase the number of SVD and D. So this is the slide which I want to show you. 1985 RUA, 1989 first balloon aortic valvoplasty, 94 of course the autopsy study, 99 setting up the PVT company, 2000 animal experimentation of sheep models, 2002 the first in-man done by Dr. Alan Crebier in France of 57-year-old cardiogenic shock, almost dying patient, refused by the surgeon post bypass. The 2002 to 3 the RUA feasibility study, 2004 Edwards come back again after refusing in 94 to take over the PVT feasibility studies of transfemoral and transapical CE mark, which is European European CE mark was up to established, was given in 2007, and from 2007 post-commercial registries 8 to 10 partner 1, 2010 new novel studies 16 partner 2, 19 partner 3, and expansion of all coming 37 years post BAV, 22 years after the film. And is not TAVI in 2025 they recognized medical breakthrough, a disruptive technology which can be largely applied addressing important unmet clinical need for a common disease, a benefit demonstrated by rigorous evidence-based evaluation, double impact on the pattern of medical practice. TAVI has saved life and improved the quality of life. Thousands of patients who otherwise would have been left untreated without the catastrophic outcome. In 2002 or 2006 or 8 or 10, it was said that TAVI is indicated when you cannot do SAVR, that means surgical valve replacement. But now with partner 3 showing the low risk also benefited, now they say TAVI is indicated. Surgical aortic valve replacement is indicated when you cannot do TAVI. Of course, there are financial constraints, and there are still a lot of surgeons are doing it. But I have seen that surgeons are also doing transcatheter aortic valve implantation in many countries. I don't know about India, but outside India, the surgeons had taken up the task of doing the transcatheter. This is a very important slide. I was there. This was the 20th celebration of TAVI, 600 attendees from 50 countries, and this was one of the most celebrated things. Thank you very much, Dr. Alan Crebier, for giving. And just, sorry, this is the slide meant for Ambani's wedding of few slides. Okay. So this is my final slides, which I wanted to show you regarding this. I think I have more slides. No. So this was my final slide. TAVI is important. We have to learn, everybody, interventional cardiologist and even cardiac surgeon, I would say that they should also start doing, because a lot of patients who come to surgeons directly, and they should not be dependent upon the interventional cardiologist to do it. It is not that complex a procedure. Once you have a learning curve, you will be able to do it. Thank you very much for the kind attention and also giving the opportunity to talk on TAVI.
Excellent talk, and it was really great to know the journey of evolution of this TAVI valves, and you gave great tribute to your mentor. Congratulations. Thank you.
Thank you very much, Dr. Yadav, and for a wonderful first time I'm attending this lung and transplants, but this was out of it. But I thought, and you accepted my request, and I'm thankful to you. Thank you very much.
Thank you, sir. And we'll be closing the session here, sir. Thank you so much, my respected chairpersons, and to all the delegates. This is all for day 2, and everyone is requested to proceed for the gala dinner.